those footsteps, I told Grace, everyone's such a good mood, and now we're talking about dying. So we let the air out of the room. But thanks so much for the opportunity to speak with you this morning about this topic. It is a new emerging topic, very much in the early stages, but many of you are so key to having this done well in terms of facilitating dialogue with, to make it sound pretty with our patients and clients that are pursuing this. Just one, I don't have too many funny stories about medical assistants in dying, but one story I do have was one patient that I'd gone through the process with her, and she didn't be eligible, and we were about ready to proceed. And she, looked at us and said, the only thing I'm really sad I'm going to miss is I won't know who won the presidential election. And so on election, and she said, I really hope she wins. And so on election night, I was thinking about her and, kind of gave her a wry smile thinking about that. But anyway, so today we're just going to really focus on the terminology first, just to give you a background of the legislation, how this term came to be, because it is quite important to understand, especially for many of you. I'll talk about the legal overview, so the Supreme Court of Canada Carter case, and then also the criminal code. So this is the federal legislation that really sets the foundation for the rules for how we have to follow for patients to be eligible and access this. We'll talk about the process for medical assistance in dying. I've been involved with it in the acute care context and also in the community, and actually I have more experience with it in the hospital context. I will talk about it in more resources, and then Grace will come up and focus more so on self-preparedness for deciding whether or not you can do this assignment and that type of thing. Maybe I'll just take a step back and say, I just want to acknowledge that there are probably a full range of perspectives about this issue in the room, and that's fine. Everybody has different personal values about this topic, and so we have to allow and accommodate for all of those, and that's perfectly fine. I just ask that you listen with an open mind as we go through. So some of the commonly used terminology. So there's two types of assisted dying. So physician-assisted suicide, so that's the term that you're probably used to hearing most commonly, and euthanasia. So physician-assisted suicide, and we'll talk about this a little bit more, that's when a patient self-administers or causes their own death. Versus euthanasia, that's where a physician or nurse practitioner administers a substance that causes the patient's death. Now, interestingly, since we were talking about etymology just in the previous talk, so eu means good and phantos means death, right? So euthanasia literally means good death. So it's I found it very interesting when I learned that. The term from the Carter case, so this is the Supreme Court of Canada case that really was the foundational piece for changing the legislation in Canada. They use the term physician-assisted dying, or PAD, as the acronym goes. And so that includes both physician-assisted suicide and euthanasia. Both of those are permissible in Canada, and we'll talk a little bit more about that. Now, once the Carter case really focused on physicians, and then when the federal criminal legislation was passed, it used a broader term. So it acknowledged that it wouldn't just be physicians involved in this, and so they opted for the term medical assistance in dying, or MAID. Again, it includes both euthanasia and assisted suicide. Both of those are permissible, just to have that understanding. So in terms of definitions, I won't spend a lot of time on this, but assisted suicide, again, that's where the patient self-administers a lethal substance, a lethal drug that causes their death. An example is a terminal cancer patient who gets a prescription from her physician for barbiturates and takes those medications to end her life. So that's what's classically called assisted suicide. So euthanasia, very similar, except that's where the physician or also nurse practitioner is allowed to administer a lethal drug that causes the patient's death. So it's the intent to cause the patient's death, and it doesn't exactly cause the patient's death. So you can imagine taking a patient with, let's say, end-stage cancer whose physician at his request administers a lethal injection of barbiturates and muscle relaxants. So that's just in euthanasia. The best example I can give is when we euthanize pets, it's the same process, similar process. So this is not so something that's unique to Canada. There are lots of international jurisdictions that do have this. So the longest history is certainly in Europe, which the Netherlands was the first jurisdiction to have it. And there's also Belgium, Switzerland, and Luxembourg, or the Benelux countries, as we often call them. In Canada, it is legal across the country. Quebec is unique in that they only have euthanasia there, so they only have physician administration. In every other province in the country allows both. So that's the only unique piece here. There are 5 states, one additional one just did pass legislation in the election to allow it. So now there are 6. They only allow physician-assisted suicide, so patients are only allowed to self-administer there. So that's a big difference between Canada and the US. And Colombia is the only South American country that has it. So again, it's something that we've definitely seen over the past 40 years, a big shift, and that seems to be a continuing trend. So now I'll talk a little bit about the Canadian legal overview. So the Supreme Court of Canada, the Carter ruling, this was back in February 2015. So this is very legally dense language, but I'll unpack it for you. So this was a huge landmark ruling. It was unanimous. Everyone agreed that we should permit this. So what they've said is that the prohibition on physician-assisted dying is void insofar as it deprives a competent adult of such assistance where 1, the person affected clearly consents to the termination of life, and 2, the person has a grievous and irremediable medical condition that includes disease, illness, or disability that causes enduring suffering and that's intolerable to the individual with circumstances of his or her condition. So that's very dense, but let's unpack what that means. So those sections that I highlighted in yellow, those constitute what we call the Carter criteria. And so these 4 pieces are the key elements. So we have to be a competent adult, so that means able to make your own decisions. No one else can make that decision for you. Have a grievous and irremediable medical condition. So they can define what that means, but the legislation does, so I'll talk to you what that means in just a second. Have enduring suffering that's intolerable, so something that's ongoing, and it's a subjective determination for a patient to say this is intolerable to me. And they have to be able to consent to the termination of life with the assistance of a physician. Again, the Carter case was emphasizing the role of the physician. So a lot happened since that ruling in February 2015. So a 1-year moratorium was placed on that ruling so that we could have a legislative response. So ultimately that would have been early February 2016 that we would have expected to have legislation in place. That did not occur, in part because of the federal election. So that was extended to June 6th. So between February 6th and June 6th, we had what was called the interim period. So during that time, patients could apply for judicial authorization for an assisted death so they could apply to the Superior Court of their province. And we did have 13 patients in Ontario that did apply to Superior Court and get authorization for an assisted death during that time frame. So on June 6th, we didn't have federal legislation in place, and the suggestion was during that time until we have it, continue to apply to Superior Court, and that was the plan. On June 17th, the legislation was passed, and I remember this very vividly. I was sitting in my office actually helping a patient get their application ready to apply to Superior Court because it didn't know when the legislation was coming down, and I got a phone call saying it's just passed, we don't have to. So it was one of those very vivid memories on a Friday afternoon. It came into effect right away, so patients no longer had to get court orders, and they no longer have to as well. So the criminal code, this is what's in place now. So Bill C-14 amended the criminal code. And as I said before, medical assistance in dying or MAID, as we're calling it, includes, again, both physician or nurse practitioner administration as well as patient administration. So just remember that it doesn't include both. In terms of the criminal code, it's important to note what's off the table. So it does exclude primary psychiatric diagnoses. So if the reason someone's requesting medical assistance in dying is due to a psychiatric illness, so imagine I'm a person with schizophrenia and the reason I'm making the request for it is because of that psychiatric illness, I would not be eligible for it. Someone could have a concurrent mental health condition, so imagine I have end-stage metastatic cancer, but I also have a or depression. As long as I'm otherwise meet the eligibility criteria, that's fine. It's only if the main reason I'm seeking it is due to a psychiatric illness. Minors, so anyone under 18, not currently eligible. An advanced consent, so that's typically what we would call an advanced directive or living will. Those are also not permitted. So if I get diagnosed with dementia and say, you know, at a certain point in my disease progression, I would like to access this, that's not legally permitted. Someone has to be capable from the time of the request until administration. So capacity, the patient always has to be capable and they have to be able to consent for themselves. So to be eligible, you have to be eligible for a health card. So insured, a resident of the province, again, 18 years of age or older. You have to be capable to make your own healthcare decisions. And a lot of the patients that I've seen that have made requests but don't ultimately access it, they deteriorate too quickly and lose capacity, so aren't able to decide for themselves. That's the most common reason someone isn't eligible. You have to have a grievous and irremediable medical condition. I know that's a mouthful and awkward phrasing, but I'll tell you exactly what that is in the next slide. Make a voluntary request, so this means that you're freely making the request. No one's coerced you or pressured you to make a request. And then, as I said, you have to be able to consent to the procedure right before we administer. So the grievous and irremediable condition. So this was really where the legislation picked up on the Supreme Court ruling and flushed out what that means. And this was a very controversial piece, and there was a lot of debate back and forth about how this would be defined. So they say you have to have a serious and incurable illness, disease, or disability. So that's generally fairly straightforward. Be in an advanced state of irreversible decline in capability. So you're essentially going down a trajectory, a downward trajectory. The third one is probably one of the easiest criteria because it's subjective. So the patient says that I'm experiencing physiological or psychological suffering that's intolerable. It cannot be believed under conditions they find acceptable. So that means that even if there are treatments available to them that might be helpful, if they don't want to accept that treatment, they do not have to. And the most controversial piece, their natural death has become reasonably foreseeable because that's pretty vague, right? It doesn't give a time frame, it doesn't say 6 months or less. It's just taking into consideration the circumstances, the general circumstances of the patient. So that's very subject to interpretation as to what that means. Any questions on the legal piece before I move on? So the process for medical assistance in dying. I just want to talk a little bit about what this looks like in practice to give you a sense of what you might expect. So there are a few different models. Again, I'm focusing largely on the acute care context. So there's what I call the parachute-in model. So that's typically where you have a team of people that have been trained and they facilitate all the assessments and administer, prescribe and administer the medications. Several hospitals have that model. So if you are working in those contexts where they have it, you'll be dealing with kind of a stable team of people. And certainly some of the pros of that model is that you do have significant expertise built up in that group. They're used to dealing with this, and that's a huge bonus. The con is certainly the potential for stigma. I've heard people refer to them as the death squad and that sort of thing. So that's certainly not something most people want to sign up for, right? So another downside is that it doesn't integrate it as much. It's something that's done over there by that group of people, and not necessarily something that everyone in terms of the healthcare continuum feels ownership of. The wraparound model, so this is what we've adopted at Sunnybrook. So our plan is that wherever a formal request arises in the patient's journey, that local team is responsible for facilitating the request. And if we don't have anyone in that local area that's willing to be a primary wraparound supports, we do have a list of people that have self-identified as willing to participate, and we wrap around those supports and help facilitate it. So the pro of that model is it does integrate it with usual care instead of making something separate and distinct. The con is that you're not going to have as much expertise and all of this quickly is going to take longer to do. In reality, the number of people that are willing to be primaries, i.e. administer, are fairly small. So we do have a good bit of expertise that gets built up just by virtue of a low number of people that are willing to be directly involved. And a lot of people have a blended version of the two of those. In the community, it's going to be a little bit different. You're likely going to be dealing with a family physician or palliative care physician and a nurse in the home environment or long-term care or retirement home. And they may or may not have done this before. Hopefully, if it's their first time, they're going to have someone with them that has. That's certainly the model that we try to do. But just to give you a sense of what it looks like in practice. In terms of patient access infrastructure, and when I say that, I mean conscientious objection. I imagine that's a term. Have people heard that term before? Are you familiar with that term? So it does, or it did originate in the war military context, people that consciously object to serving in the military or fighting in wars, often for religious reasons. This has been appropriated in other contexts. And so, not surprisingly, in medical assistance in dying, there are many people that don't wish to participate in these requests. And so in terms of accommodating that, we have to have policies and mechanisms in place. So the general goal of accommodating that is to really strike a balance. So we want to protect the moral integrity of our clinicians, so they allow them to act in accordance with their conscience, not feel compelled to do anything that they don't feel comfortable with, but also protect access for our patients and clients and also other clinicians, that they're not burdened by someone else's objection. So during that interim period I talked about between February and June, many healthcare providers did create a list of healthcare providers that were willing to facilitate. So that if I'm a physician and someone asks me about it and I don't wish to participate, I know who to refer to. That was a big problem, that because we are in the early stages, no one knew who to refer to, so we tried to help that in an institutional context. Since this summer, the Ministry of Health did create a provincial clinician referral service, and so clinicians can call this and find physicians or nurse practitioners who are willing to assess their patients and provide the procedure if they're deemed eligible. So that's been a big help, especially for more rural areas that don't necessarily have clinicians locally. They have used the Ontario Telemedicine Network and those types of things to help facilitate access to patients in rural areas. So some of the practical considerations for interpreters, and Grace will go into a lot more detail about some of this, but deciding if you're comfortable accepting the assignment. That initial stage when you find out what this is for, what you have thought about it and given some self-reflection as to whether you're comfortable doing this and will be prepared. I'll share that I've been involved in many of these cases. I've been there when the procedure's been done, and it's intense. I'm not a clinician by background. I know some of you are and some of you aren't, but you have to be prepared for what you're going to see. And certainly, I always say when someone's dying, you only get a chance to do it once, so we need to do it right. So you want to make sure that the people that are involved are okay and aren't going to be upset, and certainly there's the self-care aspect of it. You don't certainly want to be upset by the experience either. So you have to think about what's your personal degree of comfort with supporting this process. Are you in principle supportive of this? It's one thing to say, yes, I support a patient's choice to do this, but it's another to help facilitate it. So think about, how are you going to respond if you're asked to witness documents? I know this is something you guys deal with and are challenged with quite often, and Grace will talk a little bit more about that as well, but, again, having that prepared response so that it's not a surprise to you if you are asked. That self-care aspect, so acknowledging that this is new and difficult. We are still in very early stages of this. And, we have to be candid and honest and say it is new, it's not easy, but, let's think about how we can do this the best possible way. So again, those are some initial considerations for you. I wanted to share some of the statistics. This is just in the province of Ontario for the end of October. Actually, I just wanted to Chief Coroner's peak yesterday, and as of Monday, there have been 140 deaths, but the breakdown is 114. Apparently, there are about 6 a week on average. Of those, 112 have been physician-administered and 2 have been patient-administered. Slight majority that is occurring predominantly in acute care in the hospital environment right now. That's very unusual. In other jurisdictions where this occurs, it's the vast majority are occurring in the community. I do expect that will change in the future. I hope it will change. But right now, I think patients are experiencing barriers in the community to access it, so people are going to acute care to access it. The underlying conditions aren't surprising. That's generally what we would expect. The bulk of patients that are accessing this are end-stage cancer patients. ALS is another big disease group. Neurological, so you're going to see neurodegenerative diseases, cardiovascular, respiratory, and then other category. So that just gives you a sense of things. What's kind of your initial impression when you see those statistics? It's what you're expecting?
Well, I see, for me, and my convictions in the belief system, I find that this is respecting the human nature, because most of these people, if we were letting nature do it, they would not be alive, and it's only artificially with medicine and techniques, and I find this is honoring the human being.
Okay. Other comments, thoughts, observations about this? Are you surprised by the number? No? Some people, I see some heads shaking yes or no. That's what most people say, is that they were surprised that there's been that many already. This is just Ontario. So we're averaging about 1 a day, which is pretty much in line with our population and what we would expect from other jurisdictions. But it gives you a sense of kind of numbers here.
How many have been rejected? Do you know many applications or?
Yeah, so that's a great question. So I don't know if everyone heard us say how many have rejected or denied eligibility. We don't have statistics on that because no one's tracking it. I can say of the cases I've been involved in, it would just be very few that have been deemed ineligible that have requested. Most patients, it would be a very small number that are deemed ineligible, and typically that's because they don't meet the reasonably foreseeable natural death criteria. So they would have certainly a horrible disease, illness, or disability, but they're not, their natural death isn't imminent enough to qualify. But what was my thought on that? In terms of those that make a request and don't access it, they typically deteriorate too quickly before we're able to get things lined up. So it does take a little bit of time logistically to get this coordinated. You'd be, let me see what I thought I had put one on here on practical challenges, but I think I took that out for the sake of time. But it does take about 48 hours to get everything lined up in terms of the assessments, medications, identifying who's going to participate, and that type of thing. Meeting with the patient, their family, and just that supportive capacity. So it's not something that can be done on very short notice. It does take a bit of time. And we can probably actually coordinate it faster in the hospital than we can in the community. But that's just kind of a logistical reality. Maybe I'll talk a little bit about some of the pragmatic challenges that have come up. One that really kind of prompted this discussion was the use of interpreters. I know I was involved in a case where we did have an interpreter. I didn't book the assignment, and then we find out the interpreter wasn't given the heads up that this is what we were talking about. So they were quite upset, not surprisingly. And I had that oh my god moment, where you just feel awful that this hadn't occurred. And I said, this can't happen again. This is not acceptable. And so that's when I reached out to Grace and we started talking about the same. How can we educate our healthcare providers that are booking the appointments? How can we prepare our interpreters? Get everyone ready so that they know what to expect and this can be done well. So that was one of the major initial early days challenges. Some of the others that come up are certainly conscious objection of healthcare providers, so finding those that are willing to participate, engaging them. We do have quite a lot of supports in place. Maybe I can just talk Sunnybrook model, and I'm not saying it's the best, or that, you know, we're doing it perfectly, but it'll at least give you a sense of things. So when a patient makes, usually it starts with a patient making what I'll call a desire to die statement. So they'll say something like, you know, I've been thinking about this, or I'd really just like this all to be over. And that really triggers an exploratory discussion to find out what that means. It could be it's just a point in time where the patient just needs their pain managed, or it could be it's something that they've been thinking about for a long time since they were diagnosed. And so it is really having that exploratory discussion to understand what it means with a healthcare provider. If it does escalate to a formal written request, that's typically when I get notified that a patient's made a formal request for medical assistance in dying, and at that stage we get two independent healthcare providers to assess them. So they'll do a written assessment and determine if the patient's eligible. Typically it's fairly obvious in those cases that the patient is, usually these are very sick people that are dying. But it can be logistically challenging. I'll use the example of an ALS patient. So at the very end of their disease progression, many of the patients might only be able to blink yes or no. And so to have a meaningful discussion with someone that's only able to blink is, as you can imagine, quite challenging. So in those situations, it's really important to have healthcare providers that have known the patient throughout their disease trajectory, and that can speak to their private discussions and the patient's capacity and that type of thing in terms of the ability to make decisions. So once we've had the two independent assessments, there is a 10-day wait period that's required by the law. So there's a mandatory 10-day reflective period. It can be waived if a patient's likely to have an imminent loss of capacity or to die. So if two independent providers agree that either of those conditions are met, that can be waived. But for the most part, I've been involved in a few cases where we waive the period, but for the most part, most patients do the 10-day wait period. And then we certainly plan in advance. Who would you like with you for the procedure? We always arrange to have it in a private room. Make sure that patients understand currently these are all coroner's cases, so after the death, we do have to notify the coroner. And just make sure everyone's aware of the supports and their options. Patients certainly are required to be notified of their alternatives to medical assistance in dying, such as palliative care. So it's a very lengthy process. It takes quite a lot of time and energy from a lot of people. There's the pharmacy aspect of it, in terms of writing the prescription, getting that filled. We administer it via peripheral IVs in the patient's arm, assuming that their veins are acceptable for that. Otherwise, we would do what's called PICC line or essential line if needed. And the procedure itself is about, only takes about 10 minutes from start to finish, so it's very fast and quite smooth and goes very well. So after that, the physician declares death, and then we would notify the coroner and provide support to the family and the team. We do have, just before the procedure, I always make sure I meet with the local team just to prepare them, especially if it's their first case, let them know what to expect and see what questions they have. After the procedure, we do a debrief, just with everyone to check in, see how everyone's doing, make sure they know what supports are available to them if they'd like to access it. And that is something that if we have interpreters involved, we do invite them to participate in that debrief. We do also, usually a week later, have a more formal debrief after people have had time to reflect a bit with the team. So that's our general process. I know that's a bit of a whirlwind, but maybe I'll pause there and see any questions about that process or any additional details that I haven't answered that you were wondering about. It's in the back.
Yeah, I'm wondering if this procedure is so clear-cut and takes only 10 minutes. Why is it that in the States there is so much problem with, let's say, whether it's to carry out an execution in the evening, where there's all kinds of things that go wrong? Are they using different drugs, or is that?
Yeah, so the question was comparing this procedure to the death penalty in the U.S. and why are there the issues there. The medications are similar. I think the challenges have been with some of the medications used in the U.S. and access to to it, and also who's doing it. Typically, you don't necessarily have a physician doing it in the U.S., and this is where we would here. So as you can imagine, not too many physicians would be very keen to participate in execution. So that is a difference. The complication rate for physician administration is extremely low. The biggest complication would be if an IV line were to blow, and that's why we always put 2 in. And we do always have redundancy built in, so there's an extra drug kit that we could use if we needed to. So there's lots of contingencies built in to make sure it goes very smoothly. I've never seen any complications. I'm not aware of any. And I just spoke to the coroner yesterday, actually, and he said he's not aware of any in our cases so far, that they've all gone quite smoothly. So that's reassuring. So I have in the back. So great question. So how is palliative care different than MAID? Really, it's the intent and goals of care. So palliative care, the goal isn't to prolong life or shorten life, it's just to make the patient comfortable. And MAID, our intent is to shorten the patient's life and to end their life, in fact. So the goals are quite different. Palliative care is very much focused on symptom relief, and that's why you've probably heard of that in the media. There is a good bit of resistance in the palliative care community to medical assistance in dying. I think some of that's historical because a lot of what they do often gets confused with medical assistance in dying. But the goals are quite different in terms of what they're trying to achieve with their patients. So that's just important to note that with palliative care, again, it focuses on symptom management, not shortening or prolonging life, just keeping the patient comfortable. And with medical assistance in dying, the goal is very much to end their life, but in doing so, stop their suffering. Does that make sense? I saw any down there.
I was just curious about the debrief. You mentioned that
Yeah.
you would meet a week after. Are the interpreters invited to the debrief post-debrief?
Yeah, so we definitely would invite them. We haven't had any to date that have attended because we've only had just a handful of cases where interpreters have been involved, but they would be invited for sure. I know you guys have done a lot of great work on the debriefing model at sick kids as well, and it was actually a group of us with several hospitals who were working on coming up with a template for the debrief. I have kind of a loose one that I have developed that just walks through some high-level steps, but yeah, we can certainly welcome to have them attend. I saw them right here and in the back.
So my question is, if this has in any way affected the protocols in the hospital, so when somebody has a terminal condition, do they get to know about C14, or they only access this if they know about it?
So it's a great question. So our patient was told about this. Currently, I think that's a little bit legally unclear. Most people feel that it's only appropriate to respond to patient requests. So I always tell healthcare providers, take cues from your patient. If the patient's asking you about what their options are, their end-of-life options are, then at that point you could. And why I say this, the risk is that the criminal code is very clear. You can't counsel anyone to end their life. You have to be very delicate in terms of how this is approached. Now, naturally, begs the question: how can someone, ask if they don't know about it? And I think that is going to take time for patients to be aware of it as an option and more resources to be developed and that type of thing. But currently, again, I just say, take cues from your patient and be responsive to their questions. And if they are asking about what are all my life options, that would be a time that you could say this is an available option to you. Again, not in a directive way or saying, I really think you should do this, but this might be an option for you. So over here.
Yeah. I heard this about out west, and I'm not sure if it's applicable to here as well. But are certain hospitals allowed to say that we're not going to provide this service, and then it was my understanding that the patient could have access by being transferred to a different hospital.
That's a great question. I think everybody probably heard that, but she's asking about institutional conscientious objection. So are institutions able to opt out of providing this. Currently they are, so if faith-based institutions are allowed to consciously reject, they cannot obstruct a patient's access, so there has been quite a bit of debate as to whether assessments can occur in those institutions or if they have to be transferred out of the institution to have the assessments done. It's quite clear the procedure can't be done on the site, but you know, as you can imagine, someone who's in frail health and end of life being transferred back and forth for assessments is not entirely patient-centered. So that is certainly lots of ongoing dialogue around that and what it can look like with particularly the Catholic faith-based institutions are exploring this. There's not a clear decision point on that yet. I've spoken with lots of my colleagues in Catholic institutions, and we're trying to at least make exceptions so that if it's going to disadvantage or cause discomfort for patients, they can at least be assessed in that institution, but would have to be transferred elsewhere for the actual procedure. So that's one of those, stay tuned, it is an unfolding situation. Sorry, I'm just checking the time. Maybe should we hold the questions, let you continue, and then we'll do a few more questions with the inquiry since we're 40 after. Okay. So for those of you that we didn't get to hold those, and we can either chat with me at the break or after Grace's done her piece, we might be able to get to them then. So thank you.
Good morning, and thank you, Lola, for inviting us to talk here at this. So I will, all questions to later. So right now this piece is about what we have to think about as we build best practices for providing interpretation in this new area of care. And so as Sally already walked us through, the first objective of this presentation was to increase your familiarity with medical assistance in dying. And then now we'd like to explore some of the considerations that we have to be talking about as we build our best practices for everyone involved. And then also, how do we begin to support you as interpreters so that you both feel comfortable and have the skills that you require to provide effective interpretation. And then, of course, remembering that this is new for all of us, so it's really good that we're all here together at this beginning stage to talk about everything that we need to talk about. So we've got some reference materials in the binder. Pages 7 to 32 relate to medical assistance in dying. We have a glossary, you have the FAQ that has been published that Sally has one of her resources. And there are also 2 of the consent forms that you can expect to have to do a site translation of. So that's really good practice for you because these are the actual Ministry of Health consent forms. So we'll talk about considerations for ISPs, the individual service providers and agencies, some considerations for you, and then just a couple of pieces, just a self-check practice, and then also just a terminology. These will be obvious to you, but we can know. So as I mentioned, these are the items that you have in the resource in your binder. And now, so we'll just jump right into the considerations for the agencies. Right from the very beginning, when we're talking about recruitment and onboarding, we need to know how do we ask new hires about their experience, training, comfort level for interpreting this area of care. And after Sonia was speaking, I'm now even more conscious of how we have to think about how we ask that question. Because it shouldn't just be, do you want to interpret for medical assistance in dying, or do you want to opt out? Because those are 2 very different questions. So maybe we can all be on the same page about how we ask that. Sorry? Okay. Then, how do we capture that choice to interpret for this area of care in our human resource management systems? So how are we capturing that so that we know who we can invite and who we can't when we're dispatching? And then what is our role as the agencies, if it is our role, in training, preparing, and supporting the interpreters for this area of care? I'm looking at Andrew because as one of the leading educators for interpreting, maybe we need to discuss whose responsibility that is. the core competency training at the colleges, so that from the very beginning, this is a part of what interpreters learn how to do. So catching up and also building it into the beginning. Now, when we're taking requests, and this is where we have to partner with the health service providers, what information do we need from the requesters? So we need to know that it's for MAID. Which MAID team members will be present? So is it the social worker? Is it someone from spiritual care? Is it one of the bioethicists? Who is there? Because that will help the interpreter prepare for the types of discussions that they might have to be interpreting. Is it just with the patient, or is it a family meeting? Because we all know you have to go in with a different mindset if it's a family meeting. At which stage in the MAID process map is this appointment that you're being booked for? So on page 31, there's the process map, all the 9 stages of MAID. Which consent forms will be used, and what are the provisions that have been made so that you can effectively prepare for the site translation? Where will the assignment take place, and what other logistics do you need to know about if it's in the patient's home? So if it is the final procedure and is in the patient's home, what has been put in place so that your working conditions are the best that they can be? And then will there be a time for a briefing and an opportunity for a debrief? So we really need to build in at least 15 minutes for a briefing beforehand so that everyone's on the same page. And then the debrief is a whole other program that we'll talk about. And then how do we accommodate requests for a specific interpreter? We've already heard that some hospitals have a best practice of not using the same interpreter more than once during the process for a patient. And then we've heard from other hospitals that they want to work with the same interpreter throughout the process. So those are 2 very different situations, and definitely requiring a whole different approach to debriefing if it's going to be the same interpreter the whole way through. So when we come to the sort of the nitty-gritty of sending out the invitations, what information do we make available at which stage in the scheduling process? And so what I mean by that is, do we include in the first invitation that it is for MAID? Now there is a potential privacy issue there because it is a very small community, and the whole community knows that there's one or 2 people who are in hospital. If that interpreter gets a request before they've accepted it, and they already know that it's for MAID, people can start connecting the dots. So we have to be thinking about that. And then how do we respond to an interpreter backing out? Because as much as we might want to set things in place so that we're dispatching these assignments to interpreters who have said, yes, I am comfortable and I feel capable in interpreting, we always need to be prepared for an interpreter in that moment to say, I can't show up at this assignment. So then we need to be responsive and understanding whenever an interpreter backs out in this situation. Because we just need to know that not everyone is going to be ready either ever or maybe at that time. So that's why I added here, we also want to be trying to strengthen and build the pool of interpreters who are able to do this. Because just because today you might not feel comfortable doing it, that's not to say that you're not going to reach out and say, can you help me build the skills and can you help me get to a place where I can interpret for this area? And then the big one, the debrief support. So what debrief supports are in place for interpreters? We need to be thinking about that. And then should the agency always remind the interpreter when they're accepting the assignment that there is debrief in place? Because again, it's like that question of how can I help you? We don't want to make the assumption that, but we want to make sure that everyone knows about it. So how do we do that well? Now, considerations for interpreters. when we're thinking about what information do we make available, this is one of those case in point of why it's so important immediately after accepting a request that you check out all the details about it, because it may not, we may not have included that it's made in that initial department description, because it might be at an inpatient unit. So check out everything that we've made available to you after you've accepted the assignment. And again, if you have to back out, please do it right away, because we're working in a very time-sensitive area of care, and so we need to work really quickly to get someone else there if you need to back out. Now, how well do you know yourself and your triggers? As you're going through the material, do a lot of self-check to see how you feel as you're reading through that material. And also do a self-check of practicing out loud in the mirror a site translation of those consent forms. Because that, you can just and look at your face and just be really aware of all of the signals that your body is giving you. Ask the agency for someone to be available for a debrief afterwards. Ask for it. Because again, we're going back to that question of, should we be offering it? Is it always an active offer? But then two, feel empowered to ask for it. And find out if a briefing has been built in and ask for that too. Because insist on at least 15 minutes of briefing with the care team so that they know how to work well with you and you know what's going to happen. Again, find out the logistics. If you are traveling by TTC, it's the winter and the final procedure is going to be in a patient's home. Find out when you get to the house, where can you sit and stay warm? But so that you're not risking an inappropriate engagement with someone else in the family. I mean, that's just a little thing, but as much as you can figure out beforehand, the better. Prepare for site translations and insist on time to prepare in advance. Again, that can figure into the briefing. And also, if you aren't being given time to prepare, your agency should back you up if you're insisting on it. So just pick up the phone and just say, I need time, because if you're compromising your ability to render a fluid site translation, you're going to be impacting on the moment. Let us back you up so you've got the time. Arrive on time and not compromising any briefing, because that 15 minutes of a briefing isn't for you to just sort of give you a window of arrival time. It's actually part of the assignment. And also, with the idea of just being in the moment, allow yourself time to get there, relax, get focused, and mentally prepare for that particular assignment. I know a lot of these are really, I feel like I'm preaching to the choir when we know all of these, but seeing them all on a list, slide after slide, I think sometimes is just a good reminder. And as much as you're going to prepare and feel good or ready going into the assignment, there might be a moment that triggers something. So remind yourself of your strategies of how to ask for a moment if you need one. And then think ahead of your strategies to remain neutral. So even if you don't need a moment to stop and step out with the washroom, ask for water, just think ahead of what you need to do so that you're keeping your head neutral and all of your other cues neutral. Now, self-care. Ask for help and support as you need it or you think that you may need it to have it in place beforehand. And check in with the care team for the possibility of a debrief. So as we heard, Anita asked, Sally has mentioned, interpreters are on the hospital's radar for this area for debriefing. And then also check in with the agency for an opportunity to debrief. And then of course maintain privacy best practices when you're debriefing. So just a quick reminder of that, leaving out any any identifying information such as names, diagnoses, location, And then, for example, instead of saying end-stage cancer, just say a terminal or palliative illness. Instead of naming a specific care facility, just say a hospice or a hospital. Okay, another area. We pride ourselves in Ontario that we are no longer using the term or the framework of a cultural interpreter. And this is an area of care where the distinction between a cultural broker and a language interpreter may become blurred at times. And so I'm just suggesting that if you're ever finding yourself with that distinction blurred, just to remind yourself that this process begins with the individual asking for this type of care. And then also that sharing a language does not mean sharing a culture. And then, of course, when we're, just as we're still sort of sometimes thinking what is the difference between cultural broker and language interpreter, and then in the whole big picture of what it is to provide language support, this is a quote that I often go back to. Mara Edelman is an advocate in the U.S. in interpreting healthcare, and she asked, should the language you speak determine how long you live? So if we can take that question and put it in the framework of, should the language you speak determine how you can access this new area of care, then we can just think about our roles in that delivery of care. So just looking at time. So just an idea of a terminology practice suggestion. We've heard a lot of different terms that have followed the trajectory of the evolution of this area of care. And I would submit that everyone in this room be prepared to be able to render as faithful an interpretation so that should the speaker say any one of these different terms in English, are you able to render that faithfully in your target languages? And then also I think it'll be up for discussion with educators and among yourselves about staying faithful to what someone has said as opposed to what you think they're trying to say. So that's just another big can of worms to get into there. And then, as for a self-check suggestion, consider the process map on page 31. And first, mark the steps at which interpretation will take place. Some of them are behind the scenes, but the majority of the steps will involve a discussion. And then do a self-check and think about interpreting of those steps. Just think, well, what would it feel like? And then mark the steps that may occur without you knowing beforehand. Now this can come up because what everyone thinks is going to be a regular check-in at bedside for an inpatient. That patient may suddenly ask to know, how do I ask about dying? And so just imagine what stages along there might pop up without us even knowing that it's going to be part of the discussion. And then this last little check-in that I'm suggesting is do that self-check again, and then be mindful of the obligations of the health service providers. Now, Sally talked about the conscientious objection, but there is a framework where there still are a couple of expectations. So first off, that physicians must not impede access to MAID, even if it conflicts with their conscience or religious beliefs. So it's access. They're not actually required to deliver it, but they can't impede the access. So two, that means that we need to build a pool of interpreters who will support physicians in carrying out that duty. And then physicians must provide the patient with information about all options that may be available or appropriate to meet the patient's clinical needs, concerns, and or wishes. So there too, we as an industry need to commit to our role of being members of the care team in that moment. So we as an industry need to build a pool of interpreters who can make sure that this mandate of the College of Physicians and Surgeons of Ontario is met. Are there any questions? No? We're gonna ask it differently. Are there some questions? Yes.
Yes, maybe a strange question. Any ideas on the legal aspects and possibly ways for interpreter to make sure that they are not sued afterwards if anything happens? So like, family could sue anybody in the process, right? So do interpreters have anything paperwork-wise, legal-wise, to cover them up in case anything comes up?
So the question was, what are the legal considerations so that should there ever be an instance, and forgive me if I'm paraphrasing correctly, should there ever be an instance where an interpreter is brought into any kind of lawsuit by a family member?
And maybe, in addition, maybe also service provider also.
Yeah, so I can maybe speak a little bit to that. So there's the criminal piece and then there's the civil piece, so the liability piece. So the criminal law is very clear that any person who assists is a physician or nurse practitioner to end a patient's life under the legislative parameters. They're exempt, you don't have to worry about prosecution. So that's very broad, it doesn't even, it could be a family member that's helping. So on the criminal side of things, you're good. What I always say, I'm a lawyer by background, you can be sued any time for any reason. The question is, are you gonna lose or win, right? And so it's always just acting professionally. All the cases I've been in, we always involve the family members. They're aware of this. At the end of the day, a capable patient has to consent in writing before we proceed. So in terms of legal protections, are pretty ironclad. I would say you continue to have good professional practice and your usual approach, and you're going to be fine. Does that mean that you couldn't be sued? That there's no way to ever eliminate that possibility, but I think it's very, very low. Is the best assurance I can give you.
So I guess two pieces would be errors and omissions insurance. And so that as an industry, most agencies will carry that for each of their interpreters. And then some interpreters also take out their own policies for that. And then when it comes to signing anything, right now the consent forms have a line for what was the title? A third party witness. And you are never a witness if you're there as an interpreter. So just that golden rule of if you're being an interpreter, you can't be anything else. And so if you're being asked to sign as a witness or as any other party on that form, no. So those would be the two.
I think those are things for adding those additional pieces. In terms of the witnesses, the day of consent, the Canadian Medical Protectors Association, they recommend there was a line for 2 witness signatures. In our model, we always have 2 physicians present, and so we'll have the one that's not administering sign. You only in theory need 1 witness to sign it. Again, this is for the day of consent that we're talking about and not the request. So typically we just have that one other physician sign it and don't worry about the second one. But I certainly direct people never to ask interpreters to be witnesses on these. But again, I think as we all know, you are unfortunately asked, so it's important to have that prepared response because again, this is going to be a very sensitive time and have a clear prepared answer if you are asked.
But sometimes, yes, it's on the page itself, but sometimes you ask, okay, someone for you writes interpreter and you sign. Someone on the bottom, you write the
Right, you'll have the assistance declaration piece. Is that what you're referring to, where it says I assisted and?
Oh, yes, or interpreter, something like that you ask sometimes, so someone.
Yeah, so a lot of consent forms do have this. The main one does not have anything.
It's kind of different, you write it
Right,
on the
right.
bottom.
Maybe Grace, I know you've given a lot of time and energy to this. I'll let you talk about it.
We haven't come up with an industry-wide best practice. We are still exploring at what point and how should the interpreter's participation be documented. And whether the interpreter should be signing as being a part of it, or if that's something that should just be documented by the physician in the patient's chart, because then there's accountability for the physician, working only with a qualified interpreter, and then that's the chain that it follows. So I would recommend that you never sign as anything other than as an interpreter, and then if you're ever asked to sign anything and you're questioning it, call the agency. And we fielded questions like that as they come up at the moment. Yes?
Thank you, Grace and Sally, for a very insightful presentation. Just some logistical questions. We all are here and hopefully we will build our teams, right, of the professional interpreters who will be capable of getting embedded to assist with the process. My question is, because in legal context, of course, the legal proceedings are postponed or never happen because of a lack of interpreters, for example, for languages of lesser diffusion. What might be the implications in this case if there is absolutely no interpreter who would be there to provide services? I'm so sorry.
It's such a dire thing to even consider, and my kind of energy fell when you said that. I guess, you know, it could be a patient doesn't get access if we're not able to get proper informed consent, right? I mean, this is something that we have to be able to have informed consent for, and if we can't facilitate accurate communication with the patient to verify that, then it could mean that they're not able to access it. So it's pretty dire consequences if we can't get interpreters to help facilitate this. So thankfully I haven't encountered that barrier yet, and I hope I never do, but it would have very significant consequences.
Out of the, you said there was 140 that have died in the last year or so?
Since June 17th.
Since June 17. Out of those 140 who have died, how many have required interpreters?
Yeah, so that's a great question. There are no statistics on that. I would guess that it's probably 10 or less would be my guess, but I don't, that's purely based on my experience of talking to colleagues, that it would be a fairly low number at this stage. But unfortunately the coroner's office is the only one who's keeping stats, overall stats, so, and to my knowledge, they're not tracking that type of information yet. It would be really helpful to track. And so I actually, now that you've suggested that, I think I will contact the coroner and ask them to track that, because it would be quite helpful to have that data.
And it's only going to swell, right? Like, the numbers are only going to swell.
Yeah.
So,
Yeah, absolutely. It would be helpful, of course, to know, which languages and all those types of things. I know there have been Mandarin and Cantonese speaking patients previously, but those are the only two languages I'm aware of so far. But again, that's just based on my limited experience. So currently the law does not allow an